podcasts, I'll be talking about some ideas that we have for the future of healthcare using AI and digital innovation. So the healthcare system has seen some digital innovation over the years, where in the past, in various settings, countries, we have been in sort of healthcare 1.0, where we use traditional care methods, manual record keeping, and primarily, if not only, face-to-face interactions with patients. Now, over time, with the digitization of the world, we've also seen that in healthcare systems. And so electronic healthcare records have been introduced. We see early sort of innovation that focused on digital being introduced into various aspects of healthcare, and some monitoring that comes along with that. And then in more recent years, we've been seeing more and more use of telehealth, telemedicine approaches, and use of advanced electronic health records. And again, that varies from country to country, but overall we're seeing a shift towards in that direction. And we're more or less now in the UK around that sort of healthcare 4.0, or we like to think that we are. We've got more comprehensive digitization across the healthcare system, and we're working towards integrating devices and the Internet of Things into that management of care, where wearable devices like iWatches, various other things that you could wear, sleep monitors, can help patients monitor their own health and help with consultations with healthcare providers. Now, where we want to be is 5.0, where there's probably going to be more focus on personalization. There's going to be more patient-centered services, and there's going to be more of empowerment of patients to take care of themselves at home through the use of digital tools that enable them to do that and improve the way that they receive care from their healthcare professionals. So we were quite interested to see where the UK stands in this, and this is now a couple of years old. So we wanted to see how telemedicine and digital health innovation has changed over time in the UK. So we used a text mining tool that we developed about 10 years ago now. And we looked at publications related to mobile applications, apps, telehealth, all those kind of terminology. And we got about just over 9,000 PubMed abstracts that sort of met the criteria. And what you can see on the slide here is that we looked at different age groups that studies have focused on. And I think it's not really surprising to see that the primary focus is on that adult middle-aged group currently. And you'll see that there's children and preschoolers, younger children, are less of the focus, as are the very older population aged 80 and over, because those are primarily harder to target populations. Of course, we're seeing a bit more of a shift in the last couple of years towards targeting those populations, but again, this is now 2 years old, so it's slightly out of date. We're also interested to see what kind of diseases we're focusing on, and are there different patterns in that uptake of digital tools in healthcare. So we looked at key diseases that we were very interested in, and that's the plot on the bottom. And what you see is each line represents a specific condition, and the number of publications related to telehealth and telemedicine digital tools for each year. And what we can see here is it's examples that the trends differ between diseases. So as one example, we can see that asthma sort of peaked in 2018, where there's a lot of focus on use of digital tools to manage asthma in the population. That kind of lost interest after that a little bit. But on the other hand, other conditions such as obesity are seeing an increase. And obviously this plot is only about 4 years out of date now, and that actually obesity has increased significantly since that point. So there are different trends, different diseases seeing more benefits of the use of digital tools, where others perhaps are slightly more limited. So that's digital health broadly. How can AI change our healthcare? And more interestingly for my group is how it changes medical research. So we do medical research using AI and other data analytical approaches. And really, AI has now seen uses across the healthcare ecosystem, if you like, from looking at imaging and using automated approaches to analyzing medical images, drug discovery, genomic analysis, pretty much any omic analysis, virtual assistants, so whether it's a chatbot or even online consultation or on-phone consultation that are using some element of AI, robot-assisted surgery that's already been adopted in several settings, remote monitoring, as I mentioned, public health and surveillance of outbreaks of disease, all those things that come with that, as well as medical device manufacturing, where AI can really improve some of the processes. But that's a very big picture, and that covers quite a lot of different things. And we're not going to go through everything today because we just don't have the time. What I would like to focus today is the primary areas where my group at Surrey is doing most of that research. So we focus quite a lot on biomarker discovery, using those big data analytics approaches, but also patient stratification, so looking for subgroups of patients in different conditions that can be managed differently than they are now, improving outcomes for those different strata of the population. But we also do some work on novel drug targeting and repurposing, where repurposing is we take a drug that's already approved, it's on the market, it's gone through that entire process of testing, validation, safety, and so on. But we look for new for medications that exist, but with new indications. So can we use a drug that's being used for disease 1, but use it for disease 2 and treat patients better? And there are lots of in silico approaches that allow us to do that. And we also do some public health and epidemiology research as well. So we'll start with biomarker discovery, and I'll show some examples of some of our more recent research. Starting with this fantastic example in chronic kidney disease. It's an area that we've been focusing quite a bit over the last 5 or 6 years. And in this study, we had a cohort of patients from the Salford kidney study. Salford is a town in northern England near Manchester. It has a fantastic hospital that we're very fortunate to be able to work with. And they have recruited just over 400 chronic kidney disease patients. We split them into two groups based on their disease progression. So we've got some patients that deteriorate quite rapidly, and we're not sure why they are different from other patients, but we know that there are those that really would progress quite quickly, where there is a group of patients that will stay quite stable for quite a long period of time. So we wanted to see whether you can predict which patients are going to deteriorate quickly versus those that are going to stay stable for a sustained amount of time using a blood test. So our approach of choice has been looking at proteins in the blood. So we use a technique called proteomics, where we can measure just over 1,000 at that time point, 1,000 different proteins in a single patient's sample. So we collected samples from the patients, run this technology in the lab, got all the data back, and that's where my team kind of really kicks in. And we used now we'd call it a simple machine learning approach. It's a predictive model to see if we can identify a subset of proteins out of those thousands that can predict whether the patient is stable or fast progressing at that specific time point. And the answer is that we were able to do that. We found a signature of 11 different proteins listed here that were really predictive of that different type of patient. And that was great and really interesting. And then what we did, we followed up that analysis with a second analysis. Rather than looking at whether a patient is stable or fast progressing, we wanted to see if we could predict clinical outcomes such as mortality and kidney failure. And those are obviously really bad outcomes for patients. It'd be great if we were able to predict whether the patient's at a very high risk of those quite early on, because that means that we can intervene quite early on. And what we found is that using the same data set with a different analysis looking at different outcomes, we were able to find a new signature that can predict mortality earlier and better than the current clinical tool that's being used in our national health service. So it actually improves on existing tools, and that's, again, using a bit of AI, machine learning in this case, and those proteomics data sets. Now, I've listed on the slides all the papers that have been published for each of these studies and examples that we will show today. So all that work has led to significant income from the Kidney Research UK charity, where we were awarded a grant to continue more work on biomarkers of kidney disease. And in this case, we were collaborating with our national registry for kidney disease patients that contains just under 3,000 kidney disease patients in the UK across 16 different centres. And in those patients, we did something called targeted proteomics, where we knew exactly which proteins we wanted to measure. There were 21 of those. We took samples from those patients and then measured those specific proteins. And these are proteins that we knew had some sort of mechanistic link to the condition or to certain aspects of the condition. And again, using some statistics and some AI, we were able to show that a model that combined some of those biomarkers with the known clinical risk factors actually outperforms in predicting clinical outcomes than those risk factors alone. So looking at the blood, looking at the biology of the patient actually improves on what we know about the disease. And more interestingly, or at least we think so, is that we found there's huge differences between men and women with chronic kidney disease. And that's something that clinicians knew to some extent, because they knew that men have a higher risk of kidney failure, they have a higher risk of death. But what we found is that risk is also captured in their biology, in the proteomics in their blood. And that in itself was very, very interesting. And again, these were two papers that were published in the top nephrology journals. So that's one example of biomarker work. But those were really good examples of where biomarker discovery kind of follows the plan, as we expect. We follow a really straightforward analysis plan. We use some clever modeling. The data's relatively simple. But what we find is if you look more globally at biomarker discovery work, many studies fail. They run the similar kind of approach and they don't end up with a biomarker that can be translated into clinic. And so we were asking, why is that the case? Why is it so many studies do fail? And what we think, which has led to a lot of the work that we've done, is that we tend to simplify disease. We tend to try and box it in a way that makes it easier for us to understand and analyze data. And that's understandable in itself, but it also means that we're missing out quite a lot. So if we take this example of this plot, we have different patients. We've got the ones symbolized in green dots, we've got the pink purple dots. And let's say I want to see which patients respond or don't respond to a certain treatment. So we've got disease severity on the y-axis. The higher up they are, the worse the patient is. And I decide to split those into two groups, the responders and the non-responders. So I've already dichotomized a continuous measure, right? I've already simplified something that's quite complex because it makes it easier for me to analyze the data. So we do that. And then in order to do that, we have to apply some threshold. We have to say over 10, they don't respond, under 10, they do respond. That threshold in many different disease areas tend to come from anecdotal evidence. Sometimes it's completely arbitrary, and it's not really supported by actual knowledge or understanding of disease, which introduces bias and error into the ways that we work. And if you look at this as an example, those two green dots that are very close to that threshold, to that dashed line, are they really that different from that one purple dot that's also close to the line? Or if I move that line just a little bit lower, that purple dot becomes green, right? So we have that kind of gray area that we're completely missing out by using this approach. We also tend to look at outcomes as a single time point. So we give patients a new medication and then we follow them for a while. And after 6 months, we see whether they responded or didn't respond. But we don't look at that time point between 0 and 6 months. We can ignore all the data that we could be collecting. And we also tend to ignore heterogeneity in the population. So we like to have clean, simple cohorts. If you think of clinical trials as the best example, they tend to recruit patients with no comorbidities, without any complexities. They want a patient with a condition, nothing else. They're going to receive either treatment or placebo, and then you're going to compare the outcomes. But the reality is most patients have complex lives. They have complex health conditions. They have all many different factors that affect their health and then would affect, of course, how they are treated. And we tend to ignore that when we do medical research. So we're able to leverage AI to help kind of overcome some of those challenges. So just briefly, and I'm just going to, like in 2 seconds, cover what is machine learning for benefit of those who don't know. Broadly, we can take machine learning, which is an approach in AI, and split it into two different kinds. We've got supervised machine learning. It's a task-driven type of modeling. It's either regression or classification, so we tend to predict a value or put things into groups. So for an example, let's say I have a bunch of stuff, and I've got all these things that are on the screen, and I have labels for those things. So some of those things are puppies, labeled as puppy, and some of those things are not puppies. So we've got a chair, we've got a banana, an apple, and a cat. Now, all these things have different characteristics that we can use to describe them. Some of them are fluffy, some have legs, some have eyes, some are edible, and so on. Taking all that data, feeding into a supervised machine learning approach, the algorithm then builds a model that can predict what is a puppy and what is a not puppy. So that's supervised in a nutshell, and it's used in many examples. The example I gave earlier on CKD was one where we used a supervised approach. More interesting approaches are the unsupervised machine learning. Now, these are data-driven. So in this case, we actually let the data tell the story. We make very few assumptions about what we know about the data. And what it tends to want to do is try and group things into meaningful groups. And what I mean by that is it will put those same items in groups where there's a high similarity within the group and a high dissimilarity between different groups. So in this crude example, it's put all the edible fruit together and it put all the cute fluffy animals together. So we've got these two different clusters within the data. But we didn't tell it how to sort the data. We didn't tell it what labels the different items in our data set have. The algorithm almost learns it for itself from the data itself. So taking that approach where we let the data tell the story, we were asked to help with a project focused on psoriasis, which is a skin condition, and I'm sure many of you have heard of. And what you see in this plot is a data set from our national registry in the UK. Each line represents a single patient over time. It's about 3 years follow-up, where the y-axis is their disease severity score called PASI. The higher up they are, the worse the patient is. And the x-axis is time. And that's a data set. That's real world data of real patients with all the complexities that come with that. So we wanted to see whether we can predict which patients are going to respond to this class of medications called biologics. They target the immune system. They are quite expensive. And currently at that point, we didn't know which patient was going to respond. And we knew that some patients do respond, some patients don't respond. And in a system where resources are restricted, you have to go, you would like to know which patient's going to respond to the treatment before you give them treatment. Because if you're treating with a medication that's not going to help, you're spending money that could go elsewhere. And also the patient isn't getting better and likely is getting worse. So obviously there's a lot of motivation to find those responders to therapy. So we applied our very, very clever unsupervised machine learning approach. And what we found is that looking at this trajectory data for patients, where each dot here is a single measure from the patient, we were able to find 4 different trajectories of response to biologics in psoriasis. And that was great because it sort of worked, but we needed to see if it made sense clinically. So we looked at the different characteristics associated with those trajectories. And we looked at different clinical measures that we had at baseline, so when they started the study. And what we found is that the pink group, which we kind of call the non-responder, so the disease severity doesn't really decrease a whole lot over time, they had higher BMI, which we know, as an example, is associated with very poor response to biologics, where the orange group, which we would consider the best responding group, which is about half of the patients, they respond very quickly, so there's a huge dip at the beginning within sort of 6 months. And they also have a lower proportion of patients with nail involvement, which we know is a risk factor for non-response. So obviously those who don't have it are likely to respond better. So that's great because we got these 4 trajectories. They clinically make sense, but that's not quite enough to be useful. So with supervised machine learning, you have those labels. So you can always test whether the algorithm is making a good prediction because you can test it against the ground truth. With unsupervised machine learning, because you're not assuming anything about the data, there isn't a ground truth, which makes validation very, very tricky. And one approach to do that is to try and replicate it in a completely independent data set. So here we have the 4 trajectories that we identified in our registry data. Luckily, we were able to access clinical trial data from biologics treated psoriasis patients. And when we apply the same model to this combined clinical trial data, we found that we can replicate those 4 trajectories in a completely independent data set and completely different patients. And the trajectories obviously look slightly different because it's not the same cohort, but overall the shapes of the trajectories are very, very similar. So that was really encouraging. It means it's not just one cohort of patients where we're saying it's not an artifact, it's actually replicating across cohorts. Now, in order to progress it a little better, we would like to be able to predict which trajectory a patient is from this onset. So we don't want to have to wait 3 years to find out they're not going to respond. Right? We want to know if they're an orange group member from day one. So we looked at a bunch of different biomarkers at baseline. And what we found is there's genetic markers that were associated with the different groups, which was encouraging. But also we looked at RNA expression and found that you can use a set of RNA molecules in blood from these patients to predict which group they're going to be in within 1 week from start of therapy. And that's very, very close to baseline. So that's already encouraging and progressing the field of sort of psoriasis and biologics treatment a great deal. Now, this approach is so appealing that we have applied it now across many, many, many different disease areas. This is just a snapshot of about 10 of those diseases. But actually, there's a few more that are not included on this slide. And in all of them, we've used some form of an unsupervised machine learning approach to try and identify stratifications within that disease population for different clinical purposes. Now, in addition to diseases, we're also quite interested to look at nutrition, because nutrition is something that affects all of us, it's part of life. And so we access the UK Biobank, which is a very, very large data set in the UK. It follows about 500,000 British people over an extended period of time. When they join the study, they give a lot of information about their health. They take questionnaires. We also give blood samples where we do genetic analysis as well as other omics, your standard blood tests, a whole range of data. Some of them also do MRI images, and it goes on and on and on. We'll go through everything. But one of the things that they do is a questionnaire on food preferences. So we wanted to know whether, if we looked at the population at large, could we identify different types of people based on the foods they say they like to eat? Which sounds kind of quirky and maybe simple, but I'll show you why that's useful. So we did just that. About 180,000 people had that particular questionnaire data. We used an unsupervised approach again, and we found that there are 3 types of people, which is a simple way to split the population, but it's one that kind of probably makes sense. So the first group in the top left corner is what we term the health conscious group. And looking at these plots, if the bar, each line on these circles represents a food type that they were asked about whether they like or dislike. If the bar is facing into the circle, they didn't like it, and the higher it is, the more they disliked it. If it's facing outwards, they liked it. So that's one way to represent these different foods and how they answer the questions. So the health conscious group, as the name suggests, liked vegetables, liked lean food, didn't like junk food, didn't like sweetened foods. They're sort of the typical, what we would call a healthy diet. Then we had the omnivore group, and they're called that because, as the name suggests, they pretty much like everything. So as you can see, all the bars in the right corner are sticking outwards. There were very few foods that they said they didn't like. So we have that particular group of people. And then finally, at the very bottom, we've got what we call the sweet tooth. As the name again suggests, they really, really liked sweet fruits, sweet beverages, white bread, all the bad things, and didn't like anything else. So you can see quite a lot of sort of facing into the circle, and only a few things are sticking out. Now, that's interesting in itself. And as we showed the results to lots of people say, oh yeah, I'm definitely the health conscious, or oh, I'm definitely a sweet tooth. But we wanted to see if there's more meaning behind that. So we looked at different characteristics for those groups. And as I said, UK Biobank has a wide range of different data types. So we looked at different measures of inflammation, different diseases. And what we found is that the health conscious had low inflammation, had low obesity, had low rates of heart disease, had better good cholesterol levels, where the omnivore group had a little bit more inflammation, more obesity, a bit more bowel disease, less good cholesterol profile, and the sweet tooth had the worst possible outcomes that you can put in this on these data sets. So they had more obesity, more diabetes, more depression, which was very interesting, and a lot more inflammation. And in addition to looking at all those characteristics, we also looked at their different biomarker data, which is also available in UK Biobank. So this is proteomics and metabolomics. We found very interesting patterns. I won't go into detail today. All that is published, so you can follow and look at the specifics. But what we thought was really, really interesting, because when we looked at the association with different diseases and these three groups, there were a couple that really popped out. So there's the obvious obesity and diabetes, which we know are going to be associated with a less healthy diet. But what we found is that there was also an association between the sweet tooth group and mental health conditions such as anxiety and depression. And that was interesting because that's a link that's already been shown a little bit in other research projects, but this is coming out of a very large data set. So we wanted to follow through, but first we wanted to see whether this could be useful. And this kind of stemmed from a conversation I had with one of my sisters, where she told me she couldn't decide which group she was in. She's sort of a healthy conscious, but she's also an omnivore, and sometimes she's a sweet tooth. How does she know which of those three groups she is? So we took the data and we simplified our model a little bit to build what this you're seeing here is a very basic decision tree, where asking only a handful of questions, so not having to go through the entire questionnaire, you can go through that tree and find out what you're more likely, which group one is more likely to be in. And there are very key factors, very specific questions that determined a lot of that decision. So one of those examples is whether you drink tea with sugar, or whether you like tomatoes. So tomatoes featured a lot, and they seem to be a really strong determinant. And once we did that, we thought, well, can we use it in a useful digital tool? So we built a framework for integrating all that information, including that classification of food type preference individuals, into a targeted intervention to reduce cardiovascular disease. If you think about apps and various nutrition tools that exist already, a lot of them will say to a certain user that, you've got bad cholesterol, you're overweight, you need to eat better, go eat some broccoli. But what if that person doesn't like broccoli? They're never going to adhere to a plan if you're going to tell them to eat things that they just don't like. So this framework actually incorporates the likes and dislikes of specific foods to tailor a dietary plan that reduces risk based on the data that we have from the UK Biobank, but also incorporates food preference into the system. So it's very likely, and we haven't tested it yet, but we are quite confident that people are more likely to adhere to a plan if it's tailored to the things that they like. And that in itself is a useful approach to think about. So finally, as I suggested, we were a little bit concerned about what kind of effect sugar has, and especially exposure to sugar in early life has on those mental health conditions later on. And because of the nature of UK Biobank, and because it recruited individuals from the age of 40 onwards, and that was about 15 years ago, we've got adults who are now much older. We've got all their health records data because they're linked through our national health system. And in the UK during the Second World War and shortly after that, there were rations of different food types. And one of the things that was rationed is sugar, because it's not grown locally, it has to be imported. And children who were conceived and born during that period of time had no exposure to sugars. or very, very little exposure to sugar. So you can almost conduct a natural experiment where you compare a group of children born during that rationing period, and we looked at the first 1,000 days of their lives, versus children born immediately after sugar was reintroduced. And in the UK, once sugar was reintroduced, once that ration was removed, the consumption went through the roof. So it immediately skyrocketed, and sugar was introduced into many, many different foods. So we looked at these different groups, the rationed versus unrationed. And what we found is that the less exposure to sugar during those 1,000 days of life, the lower the risk is for anxiety and depression later on in life. So if the child's exposed to high levels of sugar during those first 1,000 days, from the minute they're conceived until a couple of years onwards, there are a higher risk to developing these mental health conditions later on. Now, we're not assuming any kind of causality here, but the evidence does suggest that there's a really strong link in the exposure to dietary intake during those developmental stages. And there are a couple other papers from other groups who followed a similar experimental design and looked at other risk factors such as diabetes, obesity, cardiovascular disease, and found similar effects as well. So very quickly, going through some the work that we've done in the public health epidemiology fields. As I suggested, we use these unsupervised approaches across different disease areas. And one of the diseases that we've been working on is juvenile idiopathic arthritis. So this is arthritis that affects children. When we looked at trajectories of disease progression, so not in response to any specific medication, we found these 6 groups, which was quite interesting in itself. But the most interesting part is that we found this one group here that is now circled, where the objective measures of disease, the inflammation and the physician's assessment of that disease didn't match up to the child's perceived disease in themselves. So the child was experiencing poor outcome, poor well-being, but the doctors weren't seeing it. And this was so significant in this field that it was actually made it to the cover of the Lancet Rheumatology, and they drew a fantastic image for us where you can see the doctors sort of ignoring the child patient and the symptoms that what the child is experiencing. And all that came through the use of clever AI applied to data without making any kind of assumptions of what we think we know about the disease. And we found something that is a real concern, because there are patients who are objectively look like they're improving, but their perception of their disease isn't. And so obviously there's something that we're missing in the way that we're treating them. We also carried on this work and looked at responses to treatment. In this case, it's a drug called methotrexate. We found similar patterns, similar issues. I won't go into too much detail, but what I do want to note is that AI is really easy to do in isolation. And sometimes especially when it's a black box type of AI, where you don't understand what's going in the model, it's very hard to then translate that, because the communities that are going to be affected by that model don't necessarily trust how the model got from A to B, and it's very hard to explain that. So we've taken a slightly different approach, again in juvenile idiopathic arthritis, where we've involved the patients themselves and the clinicians in the whole process of developing a machine learning model. So we had a series of workshops where we showed them how machine learning was applied. We showed the different types of results that we get. And then we asked them, does any of this resonate with your experience of your disease? Does it resonate with your experience of your patients? And that in itself was a very engaging and interesting conversation to have. And there were things that they pointed out that the machine learning missed, and there were things that they pointed out, they said that was exactly how I mean, it really this algorithm really captured my experience of my disease. And that was a very enlightening process, also being published in a journal. So thank you very much for having me. I hope that was inspiring and interesting. Thank you.